this morning, everybody. Okay, frontline targeted therapy for advanced EGFR-positive disease. So these are the updated NCCN guidelines, and you're going to notice that there's a bit of a change. So for patients who are found to have sensitizing EGFR mutations, the recommendation, if that's discovered prior to any chemotherapy, is for one of four agents, either Erlotinib or afatinib or gefitinib or osimertinib. So we're going to talk about why those are the agents. So oncogenic drivers are found in non-squamous non-small cell lung cancer about 50% of the time, and a lot of it depends upon the patient population being tested. EGFR mutations, again, depending on the population, represent 15 to 40% of the mutations that are discovered. Also in the ERB2 category are HER2 mutations, which are much less common, about 2 to 3%. Within the EGFR mutation category, the most common and found in 86% of patients are either going to be the exon 19 deletion and the L858R. And these are the classic sensitizing mutations that respond to the EGFR inhibitors. First and second generation inhibitors being Erlotinib, gefitinib, and afatinib, and those are FDA approved for this indication. Then the third generation drug, osimertinib, is approved for the T790 mutation, which we'll be discussing. That's the most common cause of resistance to the first and second generation EGFR mutations. So there are no approved therapies for other EGFR mutations that we sometimes see. Exon 20 are classically not sensitive to the EGFR TKIs. They occur about 7% of the time, and then they're the ones on exon 18, the more uncommon ones that sometimes can respond, but not as robustly usually as the more common EGFR mutations. So these are the FDA-approved indications. So Erlotinib is approved for metastatic non-small cell lung cancer in patients whose tumors have an exon 19 deletion or exon 21. That's where the L858R is located. And for Erlotinib, it's for first-line maintenance, second or greater line treatment. For gefitinib, they're approved for the same mutations detected by an FDA-approved test in the first line, and afatinib is also approved in the first line for the same mutations. So where did this all come from? This came from the iPass study, was the first study to indicate that an EGFR TKI was superior to chemotherapy in an EGFR mutated population. And actually the iPass study was designed at a time when it was clinical characteristics that we thought were the basis of the efficacy for EGFR TKIs. And this was an East Asian study done in minimal to never smokers, and they were randomly assigned to receive either gefitinib or carboplatin and paclitaxel chemotherapy. And overall, the patients did better on gefitinib, but then when it was discovered that the mutations might be the driving force behind who does well, and they went back and they tested patients who had a mutation, indeed it was discovered that it was only in the EGFR mutation positives that they had a dramatically superior progression-free survival if they were treated with gefitinib, whereas those who did not have an EGFR mutation did quite poorly with the EGFR TKI and had an improved progression-free survival with chemotherapy. So this was the study that really established that it was not the clinical characteristics that determined who should get the EGFR TKI therapy, but rather the mutation within the cancer. And since then, there have been a litany of studies confirming that EGFR TKIs are superior to chemotherapy in terms of response rate and progression-free survival in patients with the common EGFR mutations. And color-coded here, we've got the studies looking at gefitinib and Erlotinib and afatinib. So you'll see that the response rates were statistically better for the EGFR tyrosine kinase inhibitors, as well as the progression-free survivals. Also of note, none of these studies showed an improvement in overall survival for those patients treated with the EGFR TKIs, but a lot of these studies allowed crossover so patients could be salvaged following chemotherapy at the time of disease progression. So we have so far discussed three agents that all are better than chemotherapy for EGFR mutation-positive patients. So I think there is no doubt that this should be our primary approach for patients with EGFR mutations, but how do you choose one from the other? And that's what I'm going to discuss now, some studies that have looked at differentiating the various EGFR TKIs. The comparison studies for afatinib versus chemotherapy, Lux Lung 3 and 6, were compared to either cisplatin and pemetrexed or cisplatin and gemcitabine, with the primary endpoint being progression-free survival. And when they looked at those with common mutations, again, there was no difference in overall survival overall. However, in subgroup analyses by type of mutation in deletion 19 versus L858R, the patients who had deletion 19 within this pooled subset analysis were found to have an improved overall survival relative to chemotherapy in that subgroup. And that was not the case for patients with L858R. So it is for this reason you'll sometimes hear that for deletion 19, afatinib may be an approved agent because it was one that had shown a survival advantage. And this is the rationale for that. A comparison in Lux-Lung 7, afatinib was compared to gefitinib for patients who were found to have EGFR mutations. Afatinib has the potential advantage because it's an irreversible inhibitor of EGFR versus gefitinib, which is reversible. So patients were assigned to the standard doses, afatinib 40 milligrams a day versus gefitinib 250 milligrams per day. And indeed, the progression-free survival was improved for patients taking afatinib. The hazard ratio was 0.73, and this was statistically significant. Really no difference in the median progression-free survival. It was 11 versus 10.9 months. The bowing of the curves happens after the median. There was no difference in overall survival. The response rate was better in the afatinib arm, as was the duration of response. And this did not seem to be dependent on which mutation, whether it was the L858R or deletion 19, it applied to both of the mutations. However, this came at a cost. Afatinib is more toxic than gefitinib, and patients in the afatinib arm experienced more diarrhea, more rash, more stomatitis. 42% of those patients in the afatinib arm did require a dose reduction, as opposed to only 2% of patients in the gefitinib arm. 6% discontinued due to AEs in both arms, and quality of life was similar in both arms. So you could conclude that maybe this is one reason to choose afatinib over gefitinib because of the improved progression-free survival, but on the other hand, then you're dealing with more toxicity, and there did not seem to be a clear overall survival benefit, so that's debatable whether you would choose one versus the other. This is the study Archer 1050 that actually compared dacomitinib, which is another irreversible inhibitor of EGFR, versus gefitinib in patients with EGFR mutations, 452 patients. And this also showed that there was an improvement in progression-free survival for dacomitinib versus gefitinib, 14.7 months versus 9.2 months. Overall response rates were similar. Duration of response was superior in the dacomitinib arm. And again, this was regardless of whether it was deletion 19 or exon 21 mutation. So how about erlotinib? How does that compare to the irreversible agents? So there was no direct comparison, but this is a subgroup analysis of the Archer 1009 study, which was actually a study not specific to EGFR mutation-positive patients, but was a study looking at patients who had had prior chemotherapy who were randomly assigned to either erlotinib or dacomitinib. And there was a subgroup of patients who had EGFR mutations. For this analysis, they actually combined the phase 3 with the randomized phase 2 study that had come before and came up with 101 patients who had EGFR mutations within that subgroup who had been randomly assigned to receive either dacomitinib or erlotinib. And in that study, the PFS for dacomitinib was 14.6 months versus 9.6 months in the erlotinib arm. Not actually statistically significant. The overall response rate was similar in both, as was the overall survival. So that's looking at EGFR TKIs in isolation. This is another study looking at, in a Japanese patient population, of erlotinib alone or with bevacizumab for the first-line treatment of patients with EGFR mutations. And this actually showed a dramatically improved progression-free survival for patients who got bevacizumab in addition to erlotinib with a hazard ratio of 0.54. So another approach, reasonable approach for these patients is to the addition of bevacizumab to their EGFR TKI. This is another study looking at the same thing. This is the BELIEF study that was a phase 2 of erlotinib and bevacizumab. And this actually stratified patients with whether or not the T790 mutation could be detected de novo. And it actually found that the patients who did the very best on this phase 2 study of erlotinib and bevacizumab were those patients in whom they could detect a T790 mutation. These patients, I'll show you in a second, classically do not do very well with first and second generation EGFR TKIs. So this is suggesting that we may be able to improve the outcome for these patients with the addition of bevacizumab. The European Medicines Agency has actually approved the use of bevacizumab in combination with erlotinib for the first-line treatment of EGFR mutated patient non-small cell lung cancer as of June of 2016. A lot of us in the United States do not necessarily do this right now. There are additional confirmatory studies of this combination going on in the United States, Italy, and in China that will give us more information on this. Now, just a comment about T790 mutation. I mentioned it a couple times already, and we'll hear about it more in the next talk, but this is the most common resistance mutations. When non-small cell lung cancers become resistant to EGFR TKIs, it is most commonly due to the development of a T790 mutation. So T790 mutations inhibit the binding affinity of the standard EGFR, first and second generation EGFR TKIs, but there are other agents that are able to target this mutation. So de novo T790 mutation is actually something that can be found, although it's rare. With standard sequencing techniques, only about 2% of the time do we see a T790 mutation at the time of diagnosis. But the more sensitive the technique for testing, the more likely you are to find it. The harder you look, the more likely it is to be there, because there may be a subpopulation of the cancer that actually has the T790 mutation earlier in the disease course. So right down here, we see patients who are found to have the T790 mutation who are treated with first-generation EGFR TKIs had a median progression-free survival of only 1.5 months. So this is a patient population that has a poor prognosis, which is why the addition of bevacizumab may be beneficial for these patients. There has also been reported that a small group of patients will have germline T790 mutations, and there's been an association with familial cases of non-small cell lung cancer in that case. Now getting to osimertinib, which was the fourth and the newest addition to what we can use in the initial treatment of EGFR mutation-positive non-small cell. This is an oral irreversible EGFR TKI that is selective for EGFR sensitizing mutations, but also the T790 resistance mutation. It has less in vitro activity against wild-type EGFR and therefore less likely to cause some of the typical EGFR side effects of rash and diarrhea that we see. It was initially approved on the basis of a phase 1 study in 253 patients, in whom 138 had the T790 mutation, dose is 80 milligrams a day. This is the initial waterfall plot in the phase 1 study that showed an objective response rate of 61% and a PFS of 9.6 months in those patients with a T790 mutation. And this is the differential. Why is it approved for T790 mutation? This shows that patients with the T790 mutation did much better with treatment than those patients who did not have the T790 mutation. So now this is the probably the most important paper of this talk, and this is the FLORA study that was just presented that compared osimertinib versus standard of care EGFR TKI therapy with either gefitinib or erlotinib. So these were patients who had an exon 19 deletion or L858R and no prior systemic anti-cancer therapy. Of note, stable CNS metastases were allowed. Patients were randomly assigned to either get osimertinib at 80 milligrams a day or standard of care, which could have been either gefitinib at 250 milligrams a day or erlotinib at 150 milligrams a day. Crossover was allowed for patients in the standard of care arm who were found to have T790 mutation positivity at progression and therefore met the indication for osimertinib. And I guess I should note here that osimertinib is not with an indication for this role yet. So these are the baseline characteristics of the patients. So about 20% of patients in both arms had CNS disease at study entry. And this is the highlight of the study. So this is the progression-free survival, which was dramatically improved for those patients receiving osimertinib versus those patients receiving standard of care. The median progression-free survival for the osimertinib-treated patients was 18.9 months, which was almost double that for those getting standard of care, where the median progression-free survival was 10.2 months. Impressive hazard ratio of 0.46. That was highly statistically significant. And it didn't matter what the subgroup was. This benefit for osimertinib applied to all subgroups. It didn't matter if it was deletion 19 or L858R. It didn't matter what the ethnicity. So every subgroup favored the osimertinib treatment. And then, importantly, those patients with CNS metastases, this also favored osimertinib, regardless of patients presented with CNS metastases or had them at the time of study entry or whether they did not. Osimertinib is known to get into the blood-brain barrier better than standard of care EGFR, better than first-generation EGFR TKIs, and CNS progression events occurred in 6% of the osimertinib-treated patients versus 15% of the patients getting standard of care. So again, indicating that for patients with brain mets, this is a better treatment. So the response rates actually were not all that different for patients getting osimertinib versus standard of care. We know that the response rates are quite high for patients with EGFR mutated lung cancer who receive this treatment. So it was about 80% in both arms. But what was impressively better in those patients with osimertinib was the duration of response, 17.2 months versus 8.5 months. So patients are able to stay on treatment longer. So these are the waterfall plots of the tumor response rate for both agents, which do look similar. Now, overall survival, this is not a mature analysis, but the trend is in favor of the osimertinib. The median overall survival has not been reached in either arm. Hazard ratio is 0.63 with a p-value that looks significant, but because it's not mature, there's a more stringent criteria for an actually statistically significant p-value. But this is important to know that osimertinib survival does not seem worse. One of the concerns with using a third-generation EGFR TKI at diagnosis is that we don't have a treatment left to go to. So you could theoretically think you're better off if you start with a first or second generation, then you have something to go to, and overall survival might be better. But that does not seem to be the case. We do not seem to be denying these patients the additional therapies just because we can't go backward usually to the first or second generation EGFR TKI at progression on osimertinib. So here's the safety data. So both of these agents were very well tolerated, although the majority of patients did have an AE of some cause. But for any grade equal to or greater than grade 3, that was 34% in the osimertinib arm versus 45% in the standard of care arm. And if we look at those adverse events that we typically associate with these agents, if we look at the dermatitis acneiform, so for any grade in the osimertinib arm, that was 25% versus 48% in the standard of care arm. So again, that speaks to the fact that this is less active against wild-type EGFR, and therefore patients are less likely to have the typical EGFR-associated toxicities. So once again, here's what we have. We've got new NCCN guidelines. Again, this is not yet FDA approved for this indication, but we do have new NCCN guidelines that are favoring the use of osimertinib in addition to the other usual EGFR TKIs for the first-line treatment of patients with EGFR mutation-positive non-small cell lung cancer. And what we're going to hear about next is whether or not you start with a first or second generation agent and therefore can have the ability to test for T790 and go to osimertinib, or whether you start for osimertinib. There's going to be different strategies at progression, so we do need to clarify what that would be. We have a new opportunity for a new agent to use in the first-line treatment of EGFR mutated non-small cell lung cancer. That's that.